All right, welcome to this explainer. Today, we are tackling a massive topic in orthopedics, osteoarthritis of the knee. And we're going to zero in on what happens when the initial treatments just aren't cutting it anymore.
So let's get right to it. The big question is, once you've gone past the NSAIDs and physical therapy, what are the real surgical options for debilitating knee osteoarthritis? That's what we're breaking down. We're going to cover the clinical picture and the surgical playbook you absolutely need to know for your rotations.
Okay, but before we can even talk about surgery, we have to get on the same page about the disease itself. Let's define what's actually going on inside that joint. Now, this is super important. Knee OA is not just simple wear and tear. That's a huge oversimplification. It's a chronic, irreversible disease of the entire joint. You can see it right here. It hits all three compartments, the medial, the lateral, and the patellofemoral. So we're not just talking about cartilage getting worn down. This is a process that involves everything, the bone underneath, the synovium, all the surrounding structures. It's a whole joint problem.
You know, a lot of the time we label it as primary or idiopathic, meaning we don't know the exact cause. But a good clinician always hunts for secondary causes. You've got to ask the right questions. Did the patient have a congenital issue, like knock knees? What about a bad fracture in the past, say to the distal femur or tibia? And of course, you have to consider things like rheumatoid diseases or even a history of purulent arthritis. Any of these can kickstart or accelerate the whole degenerative process.
All right, so we know the pathology. Now, how does this actually look in a patient? What are you going to see when you walk into that exam room?
So the patient's story is often a classic one. It usually starts with pain after they've been active. But as things get worse, that pain can start waking them up at night. When you examine them, you might see a clear deformity, either varus, bow-legged, or valgus, knock-kneed. You'll probably see some swelling, that classic joint effusion from synovitis. And their range of motion, it's often limited, especially in the later stages where they can't fully extend the knee. And then there's the big one, that palpable, audible grating, the crepitus.
Yeah, let's zoom in on crepitus for a second because this is a huge physical exam finding. You can literally feel it. When you take the knee through its range of motion, that crunching, crackling sensation, that's the sound of bone on bone, of those damaged cartilage surfaces just grinding together. It's one of those things that once you feel it, you'll never forget it. It's a direct signal of what's happening inside.
So when the PT, the injections, and the NSAIDs just aren't enough anymore and the patient's quality of life is really suffering, that's when we get to our main question. It's time to talk surgery.
And there's a whole spectrum of options here. It's not just one size fits all. We can start with less invasive stuff like an arthroscopic cleanout. Then we move into bigger procedures that try to preserve the joint, like an osteotomy. Then, of course, there's the big gun, knee arthroplasty, which can be partial or total. And finally, for the really tough end-stage cases, there's knee arthrodesis, basically fusing the joint, which is a total salvage move.
Okay, this is a fantastic way to think about the two main strategies, osteotomy versus arthroplasty. They're based on completely different philosophies. With an osteotomy, the whole idea is joint preservation. You're not replacing anything. You're surgically correcting the limb's alignment to shift the weight off the damaged part of the knee. The goal here is to buy time, especially for a younger, more active patient. Arthroplasty, on the other hand, is all about joint replacement. You're going in, cutting out the damaged surfaces and putting in a prosthesis. The goal here isn't to delay things. It's to give definitive pain relief and get function back. It's two totally different mindsets.
Okay, let's wrap this up. What are the absolute must-know, high-yield points from all this? So, to sum it all up, first, remember knee OA is a disease of the entire joint, all three compartments. Second, don't forget to dig for those secondary causes. They're critical. Third, the classic signs are that progressive pain, the axial deformity, and that palpable crepitus. And fourth, the surgical ladder goes from joint-preserving osteotomies to joint-replacing arthroplasties. And way at the end, for salvage, you have knee arthrodesis. Got it? And this all leads us to one last really important thought. With all these surgical options on the table, how do you actually choose the right one for your patient? There's no simple flowchart. You have to consider everything. Their age, how active they are, the type and severity of their deformity, and which parts of the knee are affected. Tailoring that treatment plan to the individual, well, that's not just science, that's the art of medicine.